Hello, everyone. Welcome. My name is Lucy. I'm the Senior Manager of Community Engagement for the Myotonic Dystrophy Foundation, and I'm here to welcome you to Breathe Easy, Sleep Sound, Managing Sleep and Pulmonary Health with DM1. So now it's my pleasure to introduce our two presenters. So first, I'll start with Dr. Cynthia Bodkin, who's an Associate Professor of Clinical Neurology and Physical Medical Rehabilitation at Indiana University School of Medicine. She joined IU School of Medicine in 2008. Dr. Bodkin has a special interest in neuromuscular diseases and sleep disorders. She is currently the director of the Neurological Outpatient Clinic at the Neuroscience Center, the Muscular Dystrophy Association Clinic, and co-director of the ALS Clinic. Dr. Bodkin graduated from the State University of New York Upstate Medical School in Syracuse. Her neurology residency and clinical neurophysiology fellowship were completed at the Mayo Clinic in Jacksonville, Florida, and her sleep medicine fellowship at Hennepin County Medical Center, Minnesota Regional Sleep Center. I'd also like to introduce Dr. Gabriel Bosslet, who is a professor of clinical medicine in the Division of Pulmonary Critical Care, Sleep, and Occupational Medicine, and is the Assistant Dean for Faculty Affairs and Professional Development. He's an affiliate faculty member at the Charles Warren Fairbanks Center for Medical Ethics. Dr. Bosslet is also the president of Good Trouble Coalition, a coalition of Hoosier public health stakeholders who collaborate to educate, empower, and facilitate political advocacy to improve public health in Indiana. He lives with his wife and 4 kids and enjoys running, reading, and hanging out with his family. So please join me in welcoming our 2 presenters.
Thank you, and thank you for inviting me and coming to our talk. I know this is towards the end of the conference, so you guys must be tired, maybe sleepy by now. So perfect time for the talk. I'm going to start with sleep disorders and myotonic dystrophy. And this actually doesn't just go for myotonic type 1, but 2 as well. I have no conflicts of interest to declare, and we're going to have plenty of time for questions at the end. So sleep disorders are very common in myotonic dystrophy. They include excessive daytime sleepiness, restless legs, trouble falling asleep, and sleep disorder breathing. So we'll start off with excessive daytime sleepiness or hypersomnia. This is, by definition, unable to constantly achieve and sustain wakefulness and alertness. So this is sleepiness, falling asleep at times you don't want to or inappropriate times. It wouldn't be someone falling asleep around 1 o'clock in the morning when they're watching TV. That is considered normal. But trying to falling asleep uncontrollably at 11 o'clock in the morning, that would be abnormal. This is different than fatigue, exhaustion, or weakness. This is falling asleep. And so people will take naps frequently, fall asleep in the car, maybe fall asleep watching TV. At times they don't want to. So why do we care about being sleepy? Besides quality of life, we do see more accidents, motor vehicle accidents, missing work or school, reduced productivity. You may do poor in school, academics. You can also suffer from depression and anxiety because you're sleepy all the time. And it may impact relationships if you're having to sleep more than your partner. So how do we treat daytime sleepiness? With all sleep disorders, sleep hygiene is by far the first thing that we all need to do. This is having a nice place to sleep, go to bed at the same time every night, wake up at the same time every morning. And that's 7 days a week. Giving yourself opportunity to sleep, a good 8 hours or 9 hours to sleep if you're having troubles with daytime sleepiness. Getting bright light during the daytime. The light during the daytime, natural light, lowers our melatonin levels and tell us it's time to be awake. It's daytime. And then avoiding light at night. That's hard in Indiana in the summertime. We probably should be more central time zone. But avoiding bright lights at night because the light will lower your melatonin level. And when it gets dark out, your melatonin levels go up. And then 2 hours later, you get sleepy. And then sometimes we have to schedule naps so that you don't fall asleep inappropriately or when you don't want to. We'll schedule naps maybe at 1 o'clock every day or certain time to help you function throughout the day. If that doesn't work, then often we use stimulant medications. These are medications that help keep you awake. They're caffeine, but a little bit stronger. They all can cause jitteriness, increase heart rate, blood pressure, and they can also increase some anxiety and headaches. They also can decrease your appetite as well. Obviously, if you're having a lot of heart issues, as we know is common with myotonic dystrophy, we want to make sure that your cardiologist is okay with these medications. And they're all prescription. And then we'll move on to restless legs. Restless legs is the unpleasant, uncomfortable feeling in your legs, like you need to move them around. It may be creepy, crawly, achy, hard to describe. And people will sometimes have trouble falling asleep because their legs are bothering them. You can also see what we call a triple reflex response and movement in your legs. So you'll see like a flexion at your hip, knee, and ankle, like this. So that can happen. That movement can happen in your sleep. It may not bother you, but it can bother your bed partner because you're kicking all night and they may be woken up. And so we can frequently see this causing trouble falling asleep. We can see restless legs with iron deficiency, antihistamines like Benadryl, famotidine, or Pepsid, and antidepressant medications commonly can cause restless legs. Treatment, good sleep hygiene, avoid these medications if possible. And then we do use some medications like gabapentin, pregabalin, and sometimes dopamine agonists for it. This is probably less common where hypersomnia is more common with myotonic dystrophy. Then the other one we frequently see is the night owl, trouble falling asleep. So this is someone who may not fall asleep to 2 o'clock in the morning, but then sleep till 11 or 1 p.m. And so when we look at our sleep, if you look at the top curve, that is your homeostatic drive to sleep. So that is your drive to fall asleep. So if you just woke up, you don't have very hard drive to fall asleep. But if you've been awake for 20 hours, you have a stronger drive to fall asleep. So that top curve is that power to sleep. The bottom curve is our circadian rhythm. So we all have a clock programmed into us. And usually in the morning, it doesn't have to work very hard to keep us awake. And then it goes on throughout the day. And you can see in the evening, right here, it works the strongest to keep us awake. So we're going to be most awake before it turns off. So that's why a lot of people at night get that second wind, feel really awake. I've been tired all day. And then 8 o'clock comes around or something. And now you're like, wow, I'm awake now. That is because your internal clock is working the hardest to be awake. And so when we want to see how sleepy you are, if we combine those two together to get an idea how sleepy you are throughout the day, that's what that other line is. You can see there's a little dip in the afternoon that has nothing to do with food. That's just our circadian rhythm. It's a balance between our internal clock and how long you've been awake. Now, if you take someone who is a night owl, instead of this being maybe 6 o'clock in the morning, that may be noon. And instead of this being about 10 o'clock, that could be like 2 o'clock in the morning. So if you're trying to go to bed at 10 o'clock, but your internal body is actually on the upsweep to keep you awake, you're going to have trouble falling asleep. Then if you take a nap during the daytime, you'll discharge that sleep debt. So then when you do try to go to bed, you can have trouble sleeping as well. So how do we treat those that have trouble falling asleep in the night owl? The biggest thing is keeping the wake up time 7 days a week. So waking up at the same time, no matter what. Getting bright light first thing in the morning. That is so important to get outside, get natural light. The light you get inside from these lights or the lights at home don't come anywhere near the light that you get exposed to being outside, even on a cloudy day or in the shade. Darkness at night, using the bedroom for sleep only. Don't go to bed until it's time to sleep. Lying in bed, watching TV, reading, it just tells your brain it's okay to be awake in bed, and we don't want your brain thinking that. And avoiding naps. Now, for those who have trouble sleeping at night, those are the ones I try to avoid naps. But if you are falling asleep at any time, then we do schedule naps. So there's a clear difference between those who can't sleep, those who are sleeping too much. Now we're going to move on to sleep disorder breathing. Sleep disorder breathing is also very common in myotonic dystrophy. So first we have sleep-related hypoxemia. This isn't as common, but that's when at night when you sleep, your oxygen levels just drop. And that could be related to intrinsic lung disease, something going on in your lungs. You may have pneumonia or some atelectasis, cobwebs in your lung, but not really cobwebs. Then there's sleep apnea, which is very common. There's different types. There's obstructive and central, which I'll talk about later. And then there's sleep-related hypoventilation. We'll talk about more. So we're going to start with sleep apnea. Sleep apnea is a temporary pause in your breathing, about 10 seconds at night. There's central sleep apnea is when your brain is not telling you to breathe. And then there's obstructive where your brain tells you to breathe, but it can't. The airway collapse. The central sleep apnea generally isn't as big of a concern to us as obstructive sleep apnea generally has more consequences. So if we're looking at obstructive sleep apnea, we have, if you look at that little box, we have our airway. Our airway is a certain size just based on genetics, how our face, jaw is formed. Tends to run in the families because we look like each other because of our jaw and face. But as you gain weight on the outside, we gain it on the inside too. So that plays a role as well. And then if you have a muscle disorder, your muscles are a little bit weaker, floppier, that can collapse the airway too. So you breathe in, you collapse the airway. Your body doesn't like that. It wakes you up a little bit to breathe. And so a few times, not a big deal. But if this happens multiple times, then we call it obstructive sleep apnea. We have mild is when you decrease or stop breathing 5 to 15 times an hour. 15 to 30 is moderate, and greater than 30 severe. I have people 110 times an hour, just to give you an idea of the spectrum that we see. What happens when you do this, you have troubles with daytime sleepiness, excessive daytime sleepiness, headache, memory problems, and we also see a higher risk for stroke, heart disease. Now, patients with obstructive sleep apnea do get daytime sleepiness, and treating that can help. However, myotonic dystrophy patients, they also have the hypersomnia that is not related to sleep disorder breathing. So what I talked about earlier isn't necessarily related to obstructive sleep apnea. They are sleepy just because of their disease and part of what's happening in their brain. When we look at people with obstructive sleep apnea, we can see this is their oxygen. We can see it drops down, up, down, up, down, up, down. And those are all the times they stop breathing. So that's what a typical obstructive sleep apnea patient would look like if we just measure their oxygen. And what do we do to treat it? We use a CPAP machine, a mask that goes over the nose or mouth, and it just blows air. Weight loss can help, but not always, because some of it's just how our airways formed. There are mouthpieces that keep your jaw shut and forward that help. There's an Inspire device. It's a pacemaker that goes under the skin and it stimulates your tongue to stick your tongue out. So when you sleep, your tongue goes like this. And then there's some surgeries where they move some of the soft palate, so the tongue, uvula, the hanging down thing, and the tonsils. These ones down here don't really work well with myotonic dystrophy because myotonic dystrophy patients have other things going on. And so these are generally not going to be treated. Usually the CPAP is really the only thing that's going to work for just regular, straightforward sleep apnea. The other thing that we see with sleep disorder breathing with myotonic patients is because they have muscle weakness, not just your arms and your hands and your legs, but your respiratory muscles get weak as well. And so when that happens, anytime anyone has any problems with muscle weakness in the respiratory muscles, we always see it first during REM sleep, and specifically REM sleep, dream sleep is where we see the breathing problems show up first. And that's because normally when you're in REM sleep, your body's paralyzed. You can't move your arms, your legs, nothing, except for your diaphragm and your eyes. That's why we call REM sleep, it's rapid eye movements. And some of us, when we have weak muscles like diaphragm, we also use our scalenes and our other muscles to help breathe. But during REM sleep, you can't use those. And so we'll see the breathing problem the worst during REM sleep. And so what you will see is just their O2 levels will go down because their CO2 goes up. And so their brain is telling them to breathe, but they just don't have the strength to do it. And so in sleep studies, if you were to read your own sleep study report, some people will call hypoventilation central apnea because we don't always measure CO2 in sleep studies. We do at our institution at IU, but a lot of places do not measure CO2. And so what you'll just see is a drop in oxygen or pauses in your breathing because you don't see that the muscles are actually trying to breathe. And so they'll call that central sleep apnea. But the brain is telling you to breathe. But myotonic patients, it's just the strength rather than a person that their brain just isn't telling them to breathe. And so this is the group that we see in the myotonic dystrophy patients and what we would look like in their sleep study. If we just had the oxygen, here we can see their oxygen level just drops and just stays down. So you can see this looks very different than the obstructive sleep apnea one I showed you. So this patient Their O2 stats during REM sleep just came down and just stayed there. And that's because they didn't have the muscle strength, the diaphragm, to breathe very well during REM sleep. The treatment for this is going to be bi-level. This is like a CPAP, looks like that, but gives you two pressures, one when you inhale, one when you exhale. Then there's non-invasive ventilation that can give the same settings as a BiPAP, but they have more fancier settings. But you can also hook this up to ventilation where you have a trach and you can hook it up. You could do that. And then there's a negative pressure ventilation. I don't have any patients on that. You may have some, I don't know. But it basically is this thing where it sucks your chest wall up to do the breathing for you. So those are the treatments when you have hypoventilation. So in summary, sleep disorders are very common in myotonic dystrophy, especially hypersomnia. The sleepiness is very common, unrelated to sleep apnea, and then sleep apnea and hypoventilation are the most common. Good sleep schedule is important for anyone, but when you have a sleep disorder, it's even more important. So I frequently see patients will say, I already have a sleep problem, so why do I have to have good habits? Why do I have to go to bed at the same time and wake up? It's even more important. That's like a diabetic saying, because I have diabetes, I don't need to eat healthy. No, it's even more reason why you have to eat healthy. Sleep disorder breathing in people with myotonic dystrophy is often not straightforward sleep apnea. They often have some hypoventilation as well. So it's important to have someone that treats your sleep disorder breathing that understands that myotonic patients with sleep apnea are not going to be a straightforward sleep apnea. And usually they're going to need more insight into the treatment. They may not do well with just regular CPAP. They may need BiPAP or some other treatment to help their sleep disorder breathing. And now we'll move on to the other pulmonary issues, myotonic dystrophy.
Thank you, Cynthia. I think you'll see a little bit of overlap between what Dr. Bodkin talked about and what I talk about, but the hope is that it's more complementary and not repetitive for sure. So as a pulmonologist, I direct the adult assisted ventilation clinic here at IU. So I see basically only patients with neuromuscular diseases. I have a whole panel of patients with myotonic dystrophy that I see from around the state of Indiana. And the things that I see as a problem for most of these folks and what causes respiratory and lung issues in most of the patients that I see with myotonic dystrophy fall into one of these four categories. They either have enough breathing muscle dysfunction that they have problems with clearing carbon dioxide at night, and we'll talk about that in a second, or they have a poor cough strength or a poor swallow, or they get acute problems from an illness that we have to deal with. And so I'm going to talk a little bit about all of these over the next few minutes. And so if you come to see me, you can basically expect me to ask you about these things. How is your sleep? I ask a lot about morning headaches. I'm trying to tease out whether your carbon dioxide level at night may be elevated, whether you have daytime breathing issues, how strong your cough is, whether you have swallow issues, including weight loss that's unanticipated. I look a lot for people who are starting to get malnourished because they have what's called meal stamina issues, just being able to get a full meal in because of swallow dysfunction. I'll be honest, I don't see that often in myotonic dystrophy as I do in other muscular dystrophies. And then I also ask about any recent illnesses and make sure that you're up to date on immunizations, because the best thing we can do is prevent severe illnesses before they happen. So if you think about the respiratory system in humans is like a blacksmith and a bellows, right? The blacksmith is the respiratory muscles, the diaphragm, the scalenes, the sternocleidomastoid muscles, those muscles that do the work of inspiration for us is the blacksmith who has to move the bellows. The bellows themselves are the lungs. So the lungs are relatively passive organs. The lungs do very little. So in patients with myotonic dystrophy, in normal patients with myotonic dystrophy, the lungs are completely normal. The lungs work perfectly well. It's the muscles that supply those lungs that have problems getting the air in and out of the body. And so when patients come to see me with myotonic dystrophy or any neuromuscular disease, the question that I always have is how strong are those muscles that are getting the air in and out of the lungs with every breath? And so the way that we do this, and I'm going to hope that most of you in the audience here with myotonic dystrophy have done spirometry. We do spirometry. Spirometry is a very simple test. I ask you to breathe in as much as you can and then breathe out maximally from that maximal inhalation. And that gives us a number that we refer to as the forced vital capacity. It quantifies how much air can you breathe in and out maximally with every breath. And in patients with neuromuscular disease, that number goes down, okay? Now, that number goes down for all of us after the age of 25. So I'm 47. For 22 years, my forced vital capacity has slowly declined. Patients with neuromuscular diseases, that decline can be faster. However, myotonic dystrophy actually is the declination, the decrease in the forced vital capacity is actually quite slow. I don't often see patients with rapidly progressive neuromuscular pulmonary weakness from myotonic dystrophy. Often what happens is I'm an adult. So I was trained in adult and pediatrics, but I only see patients above the age of 18 at this point. And so when I have a patient come to see me with myotonic dystrophy, their forced vital capacity will be low. So we usually grade it by the percent of predicted. They'll be 60, 65, 70% of predicted, maybe lower, but it doesn't tend to fall that quickly over time, especially when compared with other diseases like Duchenne muscular dystrophy, which tends to fall much quicker. While it falls slowly, it is often a cause of major health issues as people go on. So often people do wind up requiring some sort of respiratory support as time goes on. And you have to remember that the problem, that the lungs do two things. The respiratory system does two things. It takes in oxygen, and that's what everyone thinks about when they think about this, but it also gets rid of carbon dioxide. And in myotonic dystrophy and other neuromuscular diseases, it's this carbon dioxide issue that becomes a problem first. It's actually quite rare for me to have a patient with a pure neuromuscular disease that needs oxygen. What they generally need is help with clearance of carbon dioxide, especially at night. Okay, so Dr. Bodkin alluded to this a bit. This becomes mainly a carbon dioxide issue. Carbon dioxide issues are they're silent. You can get used to over time slowly elevating carbon dioxide issues, and they can be hard to pick up. So what do people with elevated carbon dioxide or hypercapnia, what do those people feel? They'll often complain of morning headaches. And they get up with a headache, and until what happens is they get up, their diaphragm works better when they're awake because they are controlling those muscles better. They can use accessory muscles if needed. They'll blow that carbon dioxide off, and that headache will go away. They can complain of shortness of breath during the day. They're tired. So it's hard in myotonic dystrophy because one of the features of the disease itself is daytime tiredness, but that's also a sign of hypercarbia. So I'm often trying to figure out, is this a carbon dioxide issue, or is this just the daytime fatigue that often goes along with myotonic dystrophy? And when we see hypercapnia, it usually manifests at night. And Dr. Bodkin alluded to this. I'm not going to go into this in a lot of detail, but when we do have nocturnal hypercarbia or enough pulmonary muscle weakness that it's likely that carbon dioxide levels are going to start rising at night, we will prescribe what a lot of you have heard of as BiPAP or bilevel ventilation at night. Okay. And the idea behind that is you're helping the respiratory muscles at night. When you can't use those accessory muscles to keep that carbon dioxide level low, the machine will do this for you. And so I will often start thinking about positive pressure at night for either people with symptoms of hypercarbia or with demonstrated hypercarbia, or if your forced vital capacity is getting down near 50% of predicted, half of what it should be, then I start to think about using BiPAP or something called the maximum inspiratory pressure, which is the pressure that you can generate by sucking on a straw. You should be able to generally do about 100 centimeters of water. But patients, when they get weak, if you get below 60, that's often a sign. Or if you have daytime carbon dioxide levels that are greater than 45. If we put you in the lab, if your carbon dioxide level goes above 50 for more than half of the night, that's someone who I generally want on BiPAP to get that carbon dioxide load at night down. Because the problem is, if you carry an elevated carbon dioxide level at night, eventually it's going to happen during the day as well, and we want to prevent that. And so the way that we do that with BiPAP, and I show this especially for patients with myotonic dystrophy, because what I've found in the patients that I treat with myotonic dystrophy is because of the facial muscle weakness, they don't often like to have things on their face at night. And so I put this up there to show you, number one, there are a multitude of masks to try. Don't try one and just stop. You need to find something that works best for you. Dr. Bodkin mentioned the negative pressure ventilator. I've had actually 2 patients with myotonic dystrophy on a negative pressure ventilator. It's called a Curas ventilator. I'm not going to talk about it. They're not the greatest. So if you don't like the mask on your face, we could try the negative pressure ventilator, but it sounds like a Boeing 747 in your room at night. It's so loud. But the bottom line is, I know the patients with myotonic dystrophy have difficulty with things on their faces. So just try the different masks if your doctor says it's time to start trying BiPAP. The next thing that I find is poor cough strength. This can happen in myotonic dystrophy. We measure this with something called a peak cough flow. We put a mask on your face, and we ask you to cough, and we just measure the amount of flow that you can generate. If I asked any of you without myotonic dystrophy in the room to do this, you could probably generate a number of 1,000 liters per minute of cough flow. If you start getting below 300, below 270, that starts to become a cough I worry about in not being able to clear secretions. So often in those patients, we'll recommend that they augment their cough. And the way that we do this is with a cough assist machine. Some people, you'll see vests, but I'll be honest, my opinion is that in neuromuscular diseases, I like the cough assist machine better than the vest because the problem is mainly getting things out of the main airway, not clearing things from the smaller areas. And so this cough assist machine looks like a BiPAP. It has a mask. It coordinates both inspiratory and expiratory pressures for you to cough along with, and it just augments those pressures to help you clear things out of the airway. Often when I write a cough assist for a patient, I say, listen, you're probably not going to feel like this does a lot at the beginning, but I want you to fire it up at least once a month so that if you do get an illness where you're having trouble clearing secretions, you know that machine works. You don't pull it out of the closet and you turn it on and dust comes flying out of it and it's not going to work. So I want to make sure that it works, because if you need it on Thursday and you call me, hey, my cough assist isn't working and I have a cold and I need it, I can't get you a cough assist today. I have to get it through insurance. It's probably a week process. So that's why I want to have it before you need it. Actually, pharyngeal swallow dysfunction is actually quite common in myotonic dystrophy. It doesn't become clinically apparent for a lot of patients. In other words, a lot of patients learn to live with this. It's not that big of a deal for most people, but it can lead to easier episodes of choking, fragmented swallowing, unintentional weight loss. Some patients with more advanced disease can be risk for things like aspiration pneumonia. And so in those cases, I will often ask our speech therapists to get involved to help with just giving patients tips and tricks on how to improve swallow for their specific deficits there. It doesn't often mean we need to do much different than that. Trust me, I'm not out to have people stop eating stuff by mouth. I'm not interested in that. My job is to get you to to continue to eat and be healthy as much as humanly possible as time goes on. But there are things the speech therapist can do to give you tips and tricks to assist with good swallowing. And so these are the things that I generally see in patients with myotonic dystrophy specifically, and really any neuromuscular disease. Breathing muscle dysfunction, which we treat with nighttime positive pressure ventilation when people get to a certain level of respiratory muscle weakness. Poor cough strength, which is, if it's bad enough, we will often use a cough assist. Poor quality swallow, which we often will get speech therapy involved in very severe cases. It doesn't happen often, I'll be honest, in myotonic dystrophy. We'll start to talk about things like a feeding tube, and then severe respiratory illnesses due to acute illnesses. And I don't have much to say about this, except for the fact that you need to be up to date on your immunizations, and you need to have access to a physician who can see you relatively quickly if you do get an acute illness. So in my patient with myotonic dystrophy, I tend to be relatively quick with antibiotics. I'll be completely honest with you, because I don't want you to get a bacterial infection that puts you in the hospital. So there's a lot of times my patients with myotonic dystrophy will have an antibiotic on hand at home to use, because you always get illnesses on Friday at 10 p.m. when you can't get a hold of anyone. So I want you to have stuff available for those times, and just call me if you have questions. If it's Friday at 10 p.m. and you think you need it, go ahead and take it and call me Monday morning, and we'll sort out how things are going and what we need to do. That's it. We're happy to take any questions that anyone may have about any of this stuff.
Thank you so much.
Hi. So I wake up a lot at nighttime, And something recently that's been happening in the last month, about a couple times a week, I wake up and I'm coughing and I can't catch my breath. Feels like I'm choking and it wakes me up. Is that something that could possibly, I would need something to help, like a breathing machine or something like that? Would that be something that I should get in more quickly to see a physician?
Great question. What you just described has about 30 different possibilities for what's going on. And so I don't think it's urgent. I don't think you need to see a physician this week. But certainly, if you came to see me, we would explore things like acid reflux, making sure that you aren't having silent aspiration, stuff like that. So I don't think it's a rush necessarily, but it's something that you probably want to bring up with either your neurologist or pulmonologist at your next visit, I would say.
No, I agree. And other things that we probably recommend on something like that is if you're not having reflux, things like that, we would consider a sleep study to see, are you having some sleep apnea? And that is just one of the episodes that wake you up. Again, most people with sleep apnea, they may wake up a couple times a night. Again, one time an hour is not a big deal. What's more concerning is when it's happening multiple times an hour. But most people that stop breathing multiple times an hour, they don't even know they're doing it. And the only way to know is a sleep study.
Hi, both of our sons have severe obstructive sleep apnea. They tried BiPAPs when they're little, which was a disaster. Absolutely couldn't get them to do it. So we're going through the process again. They're in their 20s. They did both sleep studies and were prescribed a BiPAP, but insurance denied it. So instead, the doctor has suggested they get a CPAP machine. And I'm just wondering, will that be, it won't be as helpful, I'm sure, but would it be helpful? And then my other question is, there are lots of advertisements for things that might replace BiPAP or CPAP. And is there anything that might be coming, having struggled with BiPAP machines for months?
With the CPAP, if your children just have sleep apnea and no hypercapnia, or elevated CO2. So if that's all they had is sleep apnea, then a CPAP could do just fine. But if they are having elevated CO2, a BiPAP is usually going to be better. And for insurance purposes, there's multiple ways to do it. One, you can have them try CPAP, and try CPAP could just be they put it on their mask and they say, I don't like this. And then you can go to BiPAP. Other things, those numbers that Dr. Bosslet put on about their FVC being 50 or the MIP less than 60, if you have numbers below that and a neuromuscular disorder, you qualify for BiPAP. So there's different ways to get a BiPAP if insurance fails. And some of the easiest is you just put the CPAP on it. And if they tell you, I don't like this, then you can go right to CPAP. Now, other options besides what we discussed, the things I see advertisement a lot is the Inspire device for sleep apnea. Again, that doesn't work if you're neuromuscular weakness. And then besides the negative pressure ventilation, I'm not sure of anything else.
There's not a lot else, honestly. So a lot of the things that I think you've seen probably wouldn't be applicable. But I do see a lot of myotonic dystrophy patients for whom CPAP is fine. So it's not like you automatically need BiPAP if you have myotonic dystrophy. It depends on the individual patient.
Okay, we have an online question. I heard sleeping on your stomach helps stop obstructive sleep apnea because your tongue won't close off your airway. Is that true?
We know that sleeping on your back, people with obstructive sleep apnea, their sleep apnea tends to be the worst on your back. On your side and your stomach, it's not as bad. Now, there are people, it doesn't matter what position they are, they still have sleep apnea no matter what position they're in, depending on the severity. We also know having the head of bed elevated a little bit, like 15, 30 degrees, can help, because if you have your head elevated a little bit, especially like he mentioned, standing, you can breathe better because gravity can help pull your diaphragm down. So if you have the head up a little bit, that kind of helps pull things down so you don't have as much sleep apnea. But you don't want just the pillow, because if you have the pillow and your head's like this, that's not good either. So you have to put something like under the mattress that kind of raise that mattress up so you're getting that chest wall up, not just the head.
If you have myotonic dystrophy, would a CPAP or BiPAP machine help or prevent any heart or cardio problems?
So we know that if you have sleep disorder breathing, using CPAP machine or BiPAP or one of those that we do see improvement in some daytime sleepiness. We can see improvement in blood pressure. We can see decreased risk for heart disease overall. The more important thing we see in neuromuscular patients that use these machines is they have an increased quality of life. So for me, I care more about the quality of life. So if you feel better, you have more energy during the daytime, to me, that's a much better reason to use it than to decrease your risk of having a stroke in the future. But it does help with those things.
I have some questions about a cough assist. So are you using that just when you're sick, and would you use that with a nebulizer, which is typically what we use?
These are great questions.
Okay.
I will tell people, I want you to use the cough assist twice a day, every day, regardless of how you're feeling. There's multiple reasons why I say this. First, cough assist has both a negative pressure and a positive pressure component. So what happens is, especially if someone's on BiPAP at night and they're using respiratory assistance at night, then they're going through the day without any respiratory assistance, without any positive pressure respiratory assistance at all. You're getting some what's called atelectasis, or collapse of the bottom parts of the lungs, depending on how severe your respiratory muscle weakness is. So the positive pressure aspect of the cough assist can help with that, because it's giving you a big breath a couple times a day. The second reason why I like people to use it twice a day is because it gets them used to using it, right? Most of my patients with myotonic dystrophy don't have colds or issues that necessitate cough assistance twice a year. It gets every other year, once a year, maybe. And so I want you to be really adept at using the cough assist, because there's a learning curve with it. And so the better you can use it when you're feeling well, the better you're going to use it when you need it in the acute setting. And so I think those are both the reasons why I actually recommend that people use it in the morning after they brush their teeth and at night before they go to bed.
Is there such a thing as preventative respiratory therapy? Are there exercises you could do or things you could do to improve your lung function?
This is a great question. And I think who asked that question? Can you raise your hand? I didn't see. Okay. I think the technical question is that we're not sure, actually. So there is something called expiratory muscle training, where you breathe against a resistance. I haven't seen any great data that's effective, like scientific data that's effective. It's usually done with a speech therapist. However, I have had patients who do think that it helps them a good bit. From my perspective, if it's something that you come across and you want to try it, I think it's great. You're not going to hurt yourself with it. It's just, I don't know that the data is really that supportive, that's effective.
If CPAP has been prescribed but has not worked well for the individual, what alternatives would you recommend?
Usually if someone doesn't do well with a CPAP, my next step would be BiPAP or bi-level. But first I would look to see how bad is the sleep disorder breathing. Is it just mild borderline? Do you have elevated CO2? If you don't have elevated CO2, meaning your muscle strength is fine and it's just sleep apnea, then an oral appliance like a mouthpiece that a dentist makes may be an option. So it depends on the individually. But if you really need some type of ventilation, either CPAP or BiPAP, then CPAP just gives one pressure. You get one pressure when you breathe in and out. It's always the same. BiPAP gives two, one when you inhale, one when you exhale. So some people find that more comfortable, so they easier to exhale, especially if you find like the pressure's too high, I can't exhale against it. That's when a bi-level would be helpful. So the oral appliance. So the main thing with the oral appliance, one, you have to have teeth. Two, they have to be in good condition. Three, they can change your bite a little bit, so you need to be followed by a dentist closely. And at first, when you put it in your mouth, you can't go from just neutral position to like your jaw all the way out. You got to go slowly. And depending on the person, some people get a little jaw pain, so you have to go slowly. It depends on the person. And anytime you put something in your mouth like that, you're going to want to digest it. So there's a lot of drooling. So you got to have a blanket because you're going to drool a lot. But for some people, they do really well. Everyone's individual. I have some patients who love the oral appliance, and then I have some people that absolutely hate it, and the vice versa with the mask. And it's great that he had those pictures of the mask. A lot of people look at it and says, "Ooh, I want that one." and they try and they don't like it. Just because it's like outfits. You think this is going to look good on you and you put it on and it looks horrible. And then there's one that looks horrible and you put it on, it looks really good. You got to try it with the mask. There's ones that you think I'm not going to like that. And then you put it on and it's, oh, actually, this is pretty comfortable and vice versa. So sometimes you have to try it.
Okay. So I got prescribed acapella, it's called, to help me cough up stuff. And one, does that work as good as that? And two, there's a bunch of settings on it. And I don't know if I should start at a certain number. I have no idea.
Yeah, the acapella actually works pretty well. So the acapella is a device. Is it the green one or is it? Okay, yeah. So it's usually green or blue, or there's also another one called I'm not going to remember right now, but what it is basically you're exhaling and it vibrates as you exhale into it. There's like a valve that kind of vibrates. And so it moves your airways. And the idea is that it sort of pulls secretions off of your airways so that you can more easily cough it up. They actually work quite well. So that's a really good entree into pulmonary clearance devices that it works especially well for patients who have a stronger cough, but still have trouble getting stuff out. So it's usually something that I would use before I would go to a cough assist machine. The settings, I don't know because there are different ones. And so I don't know. Usually the settings has to do with the resistance and the frequency of that vibration. So what I usually tell people, especially if I don't know which one that they have, is just set it to where's the most comfortable for you so that you can use it.
I might have missed this whenever she asked if you could do the nebulizer and the cough assist same time. I don't know if you answered that. Or
I didn't answer it. I should have. Yes, you absolutely can. And it's actually a really good. So we used to have IPPB devices, intermittent positive pressure breathing devices that people would use to administer nebulized medications. Those don't exist anymore. And so there are people who have used cough assist machines in lieu of those. Sometimes, so you have to ask your DME company about the interface. Sometimes they can interface it directly into the tubing. Other times depending on the machine, they don't like to. So if they don't, you could just, if you're going to use the nebulizer and the cough assist, use the nebulizer first and then use the cough assist because you want those airways as open as possible when you do your coughs.
And then, but like you said, to use the cough assist, you don't need to use the nebulizer unless needed.
It depends on the patient. It depends on the patient. Some patients I do have on twice a day. Albuterol, it just depends on the patient.
Okay, I am scheduled for an arterial blood gas test to look at CO2 levels. Will this give sufficient diagnostic information to determine if I have hypercapnia, or is a sleep study testing CO2 also needed? And then she noted she's asking this question on behalf of her daughter, who did have a sleep study about 6 months ago, but CO2 levels were not tested.
Oh man, that's such a terrific question. So it's a terrific question on a couple of different levels. First, most sleep labs will not test your carbon dioxide level at night. And so if you come to see me here in Indianapolis from, say, South Bend, which is 2.5 hours north of here, and I want to get a sleep study, I'm gonna try to convince you to get it here because I want those carbon dioxide levels. Most normal community sleep centers will not do overnight carbon dioxide testing, and I often want that in my patients with neuromuscular diseases. The arterial blood gas is actually the gold standard test for diagnosis of hypercarbia. It is a test where they stick you usually in your wrist, in your radial artery. It hurts a little bit more than a venous puncture, although it's not terrible and it's very fast. And it will definitively tell us whether or not you have daytime hypercarbia. However, you can have a daytime carbon dioxide level of 40, which is what mine is, which is what the normal value is, and still have nighttime hypercarbia because you just ride that line where you're fine during the day, but when you go to sleep, your carbon dioxide level goes up. So the answer is it's complicated like everything else. The arterial blood gas will definitively say whether you have daytime hypercarbia. And if you do, you can just assume that you have nighttime hypercarbia. And that's enough to probably for me to recommend to you that we think about doing a BiPAP machine. But if you have a daytime arterial blood gas that's normal, it's not perfectly correlated with the nighttime. So it is what it is.
There's reasons to find tests to get insurance to pay for things. And then there's things that we need, and they aren't always the same. So there's times I don't really need the ABG, but we have to get the blood gas because insurance is wanting it to prove something, which is very frustrating. But sometimes just on the regular chemistry labs, when you get regular labs, we can sometimes see signs that this person is probably retaining CO2. Now, you could have mild CO2 and not see these changes more the bicarb goes up. We can see that in some people that retain a lot of CO2 chronically. And so that can, when I see that on someone, whether it's a neuromuscular patient or just anybody, I always look, I'm like, oh, I need to check breathing numbers on this one, get pulmonary function tests. If you live in Indiana, the IU labs do all offer CO2 monitoring for their in-lab sleep studies. However, there's a shortage of these probes. And so sometimes we have them and we can do them. They do save them for when there's a shortage for our neuromuscular patients, because they understand for the neuromuscular patients, we need them. But I do know we've had trouble getting them in, but it seems to be better right now. But with everything, backlogs of everything, you never know, like it's good for a while. And then we have months where we can't get them. But right now, we seem to be doing okay getting those probes. The main thing is whoever orders the sleep study needs to put in their measure of CO2 and that you have a neuromuscular disorder, because of the shortage, we're not doing it on everybody.
Okay, I have two questions. When you do your pulmonary test where you're blowing and it seems to me that with low muscle tone, that you're not getting that grip. Do you see that, or are there other ways to do it, or does it not really matter?
It does matter. It
Yeah.
matters a lot, actually. And so there are patients that I have with myotonic dystrophy who are unable to what we call form a seal.
See,
So
that's what I
you're
think.
basically like blowing into a straw.
Right, but
and
it's
your mouth
going
has to
all
be
right.
perfectly sealing that straw in order to not, because if you're blowing outside the side, then I'm losing some of that forced vital capacity in my measurement. Number one, the respiratory therapist generally will let us know, hey, they'll call me and say, hey, this person cannot get a good seal. If that's the case, sometimes we just do our best with the numbers that we have, because if you do a forced vital capacity maneuver and the respiratory therapist calls me, the seal isn't great, but the numbers are still pretty good, then the numbers are only going to be better than what
Yeah, but when the numbers are bad.
But when the numbers are bad, that's when you don't know.
Yeah.
And so that's often when we have to go by other criteria.
Got
We have to do other things. You can try to do spirometry with a mask rather than a mouthpiece,
Oh.
but it's not as accurate.
Okay.
And generally most labs don't do it. And we don't even really do it in our lab. We just go by other criteria to get people qualified.
Okay. And then my other question is, a power lung the same as what this gentleman was talking about?
Oh, I don't know what a power lung
Okay.
is.
It was recommended to me, and it's better breathing, airstream model.
I don't know. I'm going to
Okay.
Google it.
All right. Thanks.
Yep.
For a CPAP machine or BiPAP, is it known to strengthen the lung muscles or any muscles in particular, or help with
Yeah, good.
daytime CO2 levels and
Yes. Very good question.
hypocarmia?
Yeah, so a lot of people are afraid you don't use it, you lose it. So a lot of people with neuromuscular disease are afraid, I don't want to use this because then I'm going to get weaker. And that is true with the arms and the legs, but not with the breathing. And the reason why is if you're breathing shallow, not taking deep breaths and breathing shallow. If you think of your lungs like a balloon and you need to expand it completely to get it to be healthy. But if you're not expanding it completely and you're just going just a little bit, it gets stiff and it doesn't work as well. And then he mentioned atelectasis, which is like fluid and scarring at lower ends of the lung. I explain it to people as like kind of cobwebs. That part of the lung can get permanently damaged and then it's not going to work. So by using the BiPAP or CPAP at night, you're expanding the lungs completely. You're using the whole part of the lung and keeping that lung healthy. And so studies show that people who do use neuromuscular patients who do use non-invasive ventilation like BiPAP, that the progression of the muscle weakness of the breathing muscles actually is slower. Now, with myotonic dystrophy, it's so slow that you don't really measure it. But if we do it on patients with ALS, Lou Gehrig's disease, or Becker's muscular dystrophy and things like that, we actually see that their numbers progress slower on those who use it versus those who don't. But with myotonic dystrophy, it's so slow that we can't really measure it to know how much benefit. Absolutely. That's really to get the carbon dioxide. Say that again. It can. So if you are blowing off some CO2 at night and kind of rest in the lungs at night, then during the daytime, even when you're not using it, your CO2 levels will be generally lower and you may have more strength to breathe because you rested the lungs at night.
Okay, thank you. I'm not sure if you covered this or not, but I was wondering, how do you get cough assist covered through your insurance? Do you have to have a BiPAP or CPAP in order?
No.
Just have to have a weak cough.
Yeah. You have to have a doctor who says you have a neuromuscular disease and you have a weak cough.
It's the easiest thing.
You don't generally have to quantify it. We do in our lab, but you don't. You can just have a physician say this cough is weak enough that we need a cough assist. And you have a neuromuscular disease that qualifies you. And myotonic dystrophy is one of those neuromuscular diseases. Yes.
It's actually one of the easier things to order in for me. Everything else, I have more headache trying to get approved. But the cough assist is actually one of the easiest things to get approved.
If you do have elevated CO2 levels at night and even during the day, possibly, would you expect someone that begins using a BiPAP machine to have improvement with their memory or cognitive issues?
They can. They definitely can. It's hard to know, like in patients with myotonic dystrophy, we know that just the myotonic dystrophy causes changes in the brain to cause memory problems. And so it's not going to fix that. But anybody with elevated CO2 will have memory problems. And so if we lower that, their memory can improve. So if you just have memory problems from elevated CO2, lowering that will improve that. But myotonic dystrophy, like the sleepiness, they have sleepiness unrelated to their CO2, and they can have memory problems unrelated to the elevated CO2, and it won't fix that part.
Okay, I have a question myself. My muscle strength in my legs, it seems to be fairly good, and I'm able to walk and climb stairs. But I have noticed that I slow down. I used to be a fast walker, and now it takes me forever, and I get winded. Do you think that's because of my lungs weakening, or could it be
Possibly
a combination?
So it could be if you've had a significant reduction over the years in your forced vital capacity, that could be contributing. Yes.
Okay. And then the last question we have online is, I've had a BiPAP for over a year and I'm still having trouble getting used to it or hitting the 4 hours a night. Do you have any tips?
So trying different masks can help. Using it during the daytime, not just at night, just using it during the daytime to get yourself accustomed to it. Sometimes I will lower pressure if they feel like the pressure is too high, lower the pressure. Understanding I'm not completely treating their breathing, but at least I'm getting it lower for them to get used to it. And then once they're used to it, then I can start working the pressure up to what would actually treat them. So with trial and error, there's different machines that have different settings that come with what their company says this is how you should set it for people with neuromuscular weakness. I learned I don't start it with that. I start much lower, especially for myotonic patients, because your breathing problem has been chronic, that you're used to breathing kind of shallow. So for me to go shallow to all of a sudden normal, you're probably not going to like it and feel it's comfortable. So I start lower and go slower. But then there's some people that really struggle even with the lowest number. But the best thing is keep trying different masks, wearing it during the daytime. The more you use it and try using it while watching TV, the easier you'll get to using it all night. And for insurance purposes, they don't care if you're awake or asleep. So for insurance purposes, you just need it 4 hours. They don't know if you're asleep or awake, but they will know if you just have it on and you're not wearing it. So you can't do that.
Awesome. Please join me in giving one big thank you